Hello everyone. Good evening. Good evening everyone. How are you? Good evening everyone. So how are all my hard-working doctors? How are you and how are you studying? कैसे लग रहा है? Is it audible? Is it not? It is audible. Yes? Yes everyone. Good evening. Good evening. Just okay. Now, how are all of you? How are the studies going on? Good, ma'am? All good? I know it has to be because you all are very brave kids. Okay. So now, beta, why I have decided to do all this revision series is because we know we are very near the exam, right? And we all have done the syllabus. Now is the time to revise whatever is important, right? And what is the rule? Only one rule is there for my classes, and that is just before we start, all of you have to say, I can do it, right? There is no question mark. There is nothing. There's just a full stop. I can do it. Can you all say that? Yes, of course you can say. You all have your voice box intact. Say to yourself, I can do it. Whatever the date is of the exam, whatever happens, whatever, I am going to crack NEET. I am going to get my dream seat, and more than that, I'm going to enjoy the journey. And just because for this journey, we are just little bit contributing for your revision. Fine, enjoy this journey, beta. This time is never going to come again. Never ever again. Yes, say, everyone say, I can do it. I will do it. Right? Chalo. So, let us start. Okay. Respiratory system, beta, it is a very lengthy system. है ना, हमें पता है, it is very lengthy. Physiology, the medicine, the pathology and pharmacology. Let us start. The first topic is oxygen hemoglobin dissociation curve. Very, very important. Now, what is it? First of all, see beta, you don't need to write. You all know all of this. If you really want to write something, just write the key points. Don't write the full sentences. Just revise with me, learn with me. Fine? Let's start. Now, beta, oxygen hemoglobin dissociation curve. First of all, it is a what? It is a plot of partial pressure of oxygen and saturation. It is sigmoid in shape. First question, sigmoid in shape. Why? It is because of the cooperative binding. Two very important questions. Fine? Why cooperative binding? Because each hemoglobin can combine with 4 oxygen molecules. Fine? When it combines, when the first oxygen molecule combines, it acts like a fire. Fine, for the second one. When the second one combines, the third one even gets more excited. And the fourth one gets even more and more excited. And because of this increasing affinity, we get cooperative binding, sigmoid shape. Done? After every topic, I am going to ask you few questions which you would have to answer. Fine? Now, what is very important in this curve, everyone? At a particular partial pressure of oxygen, that is 26 to 27 mmHg, the saturation is going to be 50%. This is known as P50. Done? You all know that. In the veins, PO2 is around 40 mm and the saturation is around 70%. Whereas in the arterial blood, the PO2 is around 100 and the saturation is around 98%. Right? So what is very important in this? P50. What is it? When the saturation is 50% at the partial pressure of oxygen, which is 26 or 27 mmHg. Done? Okay. Now beta, everyone, this is your whole question bank. Fine? Now, let us start. This black one, can you all see this black one? This is the normal curve. Right? The blue one is the right shift. The red one is the left shift. Right? There are two more curves which you must know. One is this purple curve, which is myoglobin curve. Myoglobin oxygen dissociation curve. And one more, which is CO curve. Carbon monoxide, when it combines with oxygen, how much more affinity is there? Carbon monoxide has 210 times more affinity for hemoglobin than oxygen. Fine. CO2 around 20 times. Carbon monoxide around 210 times. So, but still, you know, because of this carbon monoxide, in carbon monoxide poisoning, the curve is shifted to the left and it is on the extreme left. Done beta? Right shift, left shift, normal curve, sigmoid curve. And two more curve, myoglobin and carbon monoxide curve. Fine? Done? Yaad ho gaya? Now, what causes the left and the right shift? Please beta, say with me everyone. You have to learn. Say RRR. You know, you all know this movie. It is very famous, right? RRR. RRR means right side shift will occur when oxygen is removed. Fine. Right side shift of oxyhemoglobin curve will occur when we remove oxygen. So right, remove, and one more you learn, that is Bohr mein R. Right? So now you will never make a mistake. And one more R you learn, that is rise. Clear? Now every question will become very clear. Right side shift will occur when everything rises. Rise hai? Right? R. So dissociation, removal of oxygen, or oxygen will come back to the system. It will not be combined to the hemoglobin when everything rises. Okay? Everything. CO2 rises, H plus rises, no need to learn. Temperature rises, 2,3 DPG rises. Finish. But be very careful when they ask you about pH. pH is opposite H plus. Okay? So H plus rise, everything rises right side. Okay beta, any doubt? I am looking. Lecture might be available beta in the recorded. I have told you, right? Now, very important, opposite will happen in the left shift. LLL. For the left, just remember LLL. Left loves lung. And everything is low. So beta, left loves oxygen. That means binding of oxygen occurs. Right? Now everyone, this is where site, what is the site? Lung. Here what happens? Loading, attachment of oxygen occurs. Everything is low except, of course, the pH, because pH is opposite H plus. Right? Now, one more important point, in the fetal hemoglobin, everyone, fetal hemoglobin, the curve is on the left side. Why? Because fetal hemoglobin has less affinity for 2,3 DPG. Clear? Learn हुआ? 2,3 DPG से less affinity है HbF की. That is why it is on the left side. Anything which has more affinity to 2,3 DPG will be on the right side. Myoglobin curve, which we already saw. Thalassemia, cyanide poisoning, stored blood. Stored blood has left side of oxyhemoglobin curve. To correct it, we use inosine. How? I will tell you. Right? CO poisoning, extreme left. Right? Methemoglobin. Fine, beta. So these are the causes of right and left. Never make a mistake. Repeat. RRR, LLL. Fine. HbF is important. Now, coming to the 2,3-DPG topic. 2,3-DPG, what it is, we will just do. But just remember, it increases in exercise, hypoxia, high altitude, anemias, sickle hemoglobin. When you add inosine to the stored blood, in various hormones, thyroid, growth hormone, androgen. So anything, all of these things, you see exercise, we require more oxygen. So right side shift. Hypoxia, we require right side. Right matlab ke we have to detach the oxygen. Unloading of oxygen has to occur. Dissociation has to occur. Fine. So please remember these, very, very, very important. Now, let me ask you one very important question. You are going to only answer. Exercise. Blue curve hoga, left curve hoga, red one. Which one will it be? Right shift, left shift. Keep on answering, everyone. Yes. Right, left. Exercise. Exercise. HbF. Very good. Say right side, beta. Blue mat bolo, because blue to I have made it. It will not be in your exam. Fine. Very good. So tell me, if someone is having more thyroxine hormone or someone is having more growth hormone, then right side, left side. More androgens. Right side. Left side, if somebody is having, let me ask you a very simple question. Someone is having hypothermia. Hypothermia. क्या होगा? LLL, RRR. Tell me. अब इसके बाद nobody should make a mistake in oxygen dissociation curve. If this question goes, then beta, very good. Easy questions, beta, capture those in exam. Difficult questions, you may do it, you may not be able to do it. Different story. Easy question you lose the exam. Very good. Very good. Then please tell me the stored blood. Stored blood. HbF. Fetal hemoglobin. Very good. Now here only beta learn two effects. One is Bohr effect. Right? Bohr R. Right? So right side shift hai. Something is happening, right side shift. When CO2 increases, when H plus increases, then oxygen is removed from the hemoglobin and the curve shifts to the right. So Bohr is right. Right, beta? Very important. Please remember. Next is Haldane. Bohr done. Bohr is right side shift. Occurs when there occurs increased PCO2 or when there occurs increased H plus. Very good. Haldane effect is for CO2 dissociation curve. What happens when there occurs increased oxygen? Same thing, increase CO2, oxygen comes out, increase oxygen, then there occurs unloading or removal of CO2. Fine. So Haldane effect, either remember it is from the CO2 dissociation curve or remember it is from the left side, L. Right. Bohr is when it is on the right side. Chloride shift beta or the Hamburger phenomena, it is occurring in the venous blood wherein the bicarbonates are being exchanged in the RBC for the chloride. chloride, that is known as the hamburger phenomena or chloride shift. These three can come as questions, and especially the Bohr effect. In NEET, Bohr effect. If it was INI, Haldane effect. Fine. Okay. Next is myoglobin. Recent exams, we have seen questions on the myoglobin. See beta, one molecule of the hemoglobin combines with 4 oxygen molecules. But one molecule of myoglobin combines with only 1. Next, at PO2 40 mm, myoglobin is around 95% saturated. More. So more, it has more affinity for oxygen. Whereas at this same pressure, hemoglobin is only 75% saturated. Right? And very important question. Its curve is on the left side and it is rectangular hyperbola. Rectangular hyperbola. Very important. Right? Oxyhemoglobin curve, sigmoid shape. Cooperative binding. 4 oxygen molecules. 4th one, maximum affinity. Done. Myoglobin, rectangular hyperbola. Very, very, very important. In the exam, you will find these questions. Okay. Now, beta, this is another question which might come. I have told you P50 kya hota hai? Right? Now, when the right side shift occurs, what will happen to the P50? It will increase. Whereas on the left side shift, P50 decreases. You can make the diagram, you can, plot and know so that you never make a mistake. Fine. Next, 2,3-DPG. What is this? This is the main thing, which is actually shifting right and left. Fine. It is the most common organic phosphate of body. It is formed by Rappaport-Lubbock shunt. What it does? It combines with oxyhemoglobin. Simple. Uska kaam hai to combine with oxyhemoglobin and separate oxygen from hemoglobin. That is its work. In stored blood, it decreases. So that, in the stored blood, we have to provide a source of 2,3-DPG. If 2,3-DPG is not there, RBC becomes like an oxygen bomb. 2,3-DPG is something like, it is just like a person who will go to the hemoglobin and say, give oxygen. When 2,3-DPG dies, right, the oxygen remains with the hemoglobin. Now, to prevent this, we add inosine or we add a source, dextrose, or, we give adenine for ATP. So many things we add in the stored blood so that the stored blood does not lose out 2,3-DPG. Fine. So this was all about oxyhemoglobin curve. You must know it. No confusion. Kuch nahi hona chahiye. Any confusion right now? Nothing? So let's start. Again, see beta, this is something which you have to learn. I cannot explain it right now because we have to do it very rapidly. Perfusion limited gases, diffusion limited gases. Please note N2O, O2 and CO2, they are perfusion limited. Diffusion limited are CO and oxygen under hypoxic conditions. Fine. Okay, this direct question aata hai. This comes as a direct question. INI mein they might give you a graph, but not in NEET. In NEET, they don't give you a graph. Okay. So first topic done. Second topic, everyone, which you all know, I think. And it is very important. Every year question comes from this. So quickly let us revise. Control of respiration. See, respiration, we have to control it. Neuronal or chemical. Neuronal mein we have medullary centers and pontine centers. Repeat karo, learn karo. आप बताओ डॉक्टर प्रथा, हाइपोथर्मिया माने क्या? टेम्परेचर हो गया डाउन, लो माने la. Now you know the answer. If it was hyperthermia or it was hypercapnia, then rise हो रहा है, ra, right side. Fine. Okay. Then neuronal and medullary and pontine. Very important, everyone. Repeat karte jao, learn karte jao. Right? No need to write. You all have this in your notes. राइट, बट लर्न करते हैं. क्वेश्चन क्या आता है? पेस मेकर ऑफ रेस्पिरेशन. पेस मेकर ऑफ रेस्पिरेशन इज, यस, वेरी गुड, नो मिस्टेक. बेटा अभी हम रेस्पिरेटरी सिस्टम फिनिश करेंगे एंड आई डू नॉट want anyone to make a mistake in the respiratory system, be it pharmac, medicine or patho, or if we have time I will finish micro also. Fine. So जल्दी जल्दी करते हैं, learn करते जाओ. What is the pacemaker of respiration? Pre-Botzinger. Repeat question. Repeat है ये बेटा. Right. And what are the other medullary centers? Medullary centers DRG and VRG. Right, DRG is near the nucleus tractus solitarius. If you don't know, it's okay. Right, DRG is responsible for rhythmic inspiratory discharge. Right, ventral group is VRG, that is for just firing action potential. Next, pneumotaxic center, PC and AC are pontine center. Direct question can come beta. PC and AC. PC is pneumotaxic. What is the function? This you should know. So, fine tuning, it halts inspiration, switching between inspiration and expiration. That is the function of pneumotaxic center. Apneustic center, it increases depth. Basically, PCAC, they do have an effect on the depth of respiration. And it stimulates the DRG to increase the duration of respiration. So, question क्या आता है? Question ये आता है pacemaker. Then pontine center कौन सा है? Pneumotaxic, apneustic. Recent exam में question आया था on this diagram, right? So learn कर लो how it is. Pontine center सबसे ऊपर PC है, so सबसे ऊपर pneumotaxic. You know, that is what the question was. So first one is the pneumotaxic center. Then down is apneustic. Then DRG and ventral respiratory group, they are in the medulla. The pre-Botzinger is considered the part of VRG only. But if they ask you pacemaker, you will not answer VRG, you will answer pre-Botzinger. Done beta? So please, yes beta, correct Dr. Ayush. Please see this diagram very carefully. Recent exam question hai, and this might come beta. Again it might come. Fine. Okay, they might just, you know, mark ABCD and they will ask you the function. Okay, which one is responsible for the fine tuning? Pneumotaxic center. Fine. Which center is present in the medulla? Which center is present in the pontine? Fine. Okay. Next. This particular thing is little bit important. How when you cut above pons, what happens? When you cut at the mid pons, what happens? When you cut, see beta, this type of question can come, and it is, if you want to understand the concept, it is a lot of work, right? So my suggestion to you is, I know you might be having the notes for this, where when we make a cut at upper pons, vega IR cut, what happens? Please learn it. Okay, if you have not learnt it, please learn it, write it, learn it, because this is a very probable question. This is a very favorite topic of examiners. Fine. Okay, so what is important in this? See, if we make a cut below medulla, the respiration stops. If we do bilateral vagotomy, we have regular respiration with deep and slow breathing. Deep and slow breathing with increased tidal volume and decreased respiratory rate. This you must know. Fine, these two, 4 and 5, you must know. Above pons, below pons, at mid pons. Please try and learn it. Write it, try and learn it, and if possible, do learn it. Fine? Okay, Ondine curse. What is Ondine curse? Ondine curse is when a person cannot, respire, breathe when he or she sleeps. So voluntary control is present, involuntary control is lost. Fine. So this particular point, what happens at mid pons, above pons, this point you all have to do it. Fine. Okay. Next, very, very, very important chemical control, central, peripheral. First, let us do central. Central, important. This particular point is very wrong, given in many MCQ books. So right now, just note central, the direct potent stimulus is H plus in CSF, not in the blood. But the PCO2 in the blood is the most sensitive. See how you have to learn. There are central receptors which is in the central ventral. Learn like this. Central ventral. So central is present in the ventral medulla. Fine. Peripheral. Peripheral are present at the carotid and the aortic body. Body. Sinus nahi. Sinus is a baroreceptor. Carotid and aortic body is a chemoreceptor. Fine. And for the peripheral, hypoxia is a direct stimulant. But what is the most sensitive one? Again, when CO2 increases. So most sensitive stimulus for both central and peripheral is CO2. But hypoxia, beta, please remember, hypoxia stimulates the peripheral receptors and not the central receptors. Fine, everyone. Please remember this. For the central receptor, H plus in the cerebrospinal fluid, CSF, has to be there. Fine, done. Okay, one extra question which has been coming in the medical question banks, and I think you should know it because physiology, medicine, they directly pull from, the medical papers. So they are asking now, they think students know carotid and aortic body. They have graduated. Now they want to ask which cells in carotid and aortic body perform the peripheral action. So that is glomus type 1 cell. Learn kar lo. Glomus type 1. Glomus type 1. And this is a very recent question in the medical, right? In the glomus, there are type 1 cells. There is present oxygen sensitive potassium channels. So how the carotid and the aortic bodies, they are able to sense oxygen sensitive potassium channels. Fine. One more thing you learn. हो गया बेटा. Central, peripheral. Central में two stimulants are there. H plus and CO2. CO2 in blood, H plus in CSF. Done. Peripheral, oxygen, CO2 and H plus. Three stimulus are there. And which is the direct potent stimulus? Oxygen. But most sensitive for both is central and peripheral, CO2. Fine. Okay. Next. Please learn. Peripheral are not stimulated. Very important question. Somebody is having anemia. Carbon monoxide poisoning. Then peripheral receptors are not stimulated. They are not stimulated. Fine, everyone. Please note this. Glomus type 1. Oxygen sensitive potassium channels. What happens? जैसे ही बेटा hypoxia होता है. Both, Dr. Mitali, both. Sensitive है ये. Potent oxygen है. या direct stimulus कौन है? Hypoxia for peripheral, H plus for the central. Fine? Okay. Hypoxia cannot do the central. Please remember this. Okay. Next, hypoxia is always peripheral. Done? Okay. So this was a newer information because this is a recent question. So glomus type 1, potassium channels, oxygen sensitive potassium channels. What happens? Hypoxia occurs, potassium channels, they close. Once they close, potassium cannot go out. Potassium inside the glomus, right? Depolarization occurs, calcium channel open, and what happens? Similarly, as insulin was released, vesicles are there which have the acetylcholine, dopamine, ATPs. So they are released. Once they are released, what they will do? They will stimulate the various nerves. Fine. The nerves are stimulated and that is how the respiration is activated. Fine. So this particular information was a little new to you. This diagram, please learn. Okay. So this again can come. Carotid body, Aortic body, aortic sinus, carotid sinus. Where is carotid body present? At the bifurcation. You know, when the internal carotid artery, external carotid artery, when they are bifurcated, that is where it is present. Sinus is in the vessel. Fine. Sinus is a baroreceptor. Very important question. Good. Done, beta. Do not ever make a mistake in this. This is the best thing which we can learn in physiology, because questions are going to turn up from these topics only. Fine. Next, beta, the various reflexes. Let me see, any doubt? Okay, before I come to reflexes, let us quickly revise the whole little bits, you know, little questions from the respiratory physiology. I cannot see the live chat. Just give me 1 second. Okay, now I can. See, beta. Yes, Dr. Shivani, if they ask you most potent for peripheral, that will be hypoxia. But if it is most sensitive, sensitive to the wahi hoga. Direct stimulus, first stimulus, most important stimulus is hypoxia. But what do I mean when I say sensitive? I mean, suppose हम एक hypothetical situation लेते हैं. There is 1% decrease in oxygen. Fine. And there is in 1% decrease in oxygen. Second person, there is 1% increase in CO2. ठीक है? A and B person. The peripheral receptors and the chemoreceptors are going to be activated faster in the second person, because CO2 is a harmful substance for us. Fine. So that is why sensitivity is different. Done. So please learn the question, know the concept and then answer. Read the question very nicely. ठीक है? क्या पूछना चाह रहे हैं वो? Right? Are they just asking if hypoxia is for peripheral? Do you know this concept? Or are they asking you which is going to initiate the response faster? Fine? Understood everyone? Okay. Next. जल्दी जल्दी करते हैं. Quickly beta. Okay. Next, tracheobronchial tree. What are the important questions? See, it was given by ER people 23 times. Air divides. Where the important question, trachea is given the number 0 and alveoli are given the number 23. There is a conducting zone from 0 to 16. This you don't need to know, which is 1, 10, 2, 3. No need to know. Fine. If you know, very good. If you don't know, it's okay. Fine. So conducting zone is 0 to 16. Exchange zone is 17 to 23. Conducting में there will not occur any oxygen CO2 exchange. It is just conducting. So that contributes to dead space. Okay. Important question everyone. What contributes to the dead space? Done? Okay. Next. Recent question. Clara cells. Clara cells क्या होते हैं? Recent question बेटा. Clara cells club shaped, non-ciliated, non-mucus producing. They are present in the bronchioles, not in the bronchi. ठीक है? Important question. And what is their function? They have two functions. Learn करो. One function, they are stem cells. Second function, they help in the secretion of surfactant. Now, the question is, surfactant is produced by which type of pneumocytes? You all know. Which type of pneumocytes? Quickly answer. Quickly answer everyone. Type 2 pneumocytes plus Clara cell. So in one of the exams, the answer was both. Fine. How? Now these Clara cells, they produce the protein part. The protein part of surfactant. Fine. Very good. Now let us come to surfactant. Type 2 pneumocyte. Surfactant is very, very, very important. Every year you get questions, bete. Every year. Okay? So surfactant, type 2 pneumocytes. Right? Next, maximum cells are type 1. Right? They help in gas exchange. Right? Production of surfactant is around 16 to 18 weeks of intrauterine life, but action occurs at 28 weeks. right? This is the age of viability of fetus in India. Component, very important question. What is the major component of surfactant? Repeat karo, DPPC. DPPC, right? Now what is this? This is dipalmitoyl phosphatidylcholine or lecithin, and phospholipids are present. They are the maximum part. Maximum is DPPC. Little less is sphingomyelin. So sphingomyelin, the ratio of the lecithin by sphingomyelin is important for the maturation of the lung, and it has to be more than equal to 2. If it is less, then what happens? Degeneration occurs. Surfactant is not present, and we will see what happens to the lungs. Atelectasis might happen in the newborn. Fine. Proteins, we all know, Clara cells. Lipids, carbohydrate and calcium, they are all the components. But this is the question. DPPC. Fine. What is the function? Second question. It decreases surface tension. What is surface tension? Surface tension is, suppose this is a bubble, right? So it is a tension which is causing the bubble or anything to collapse, right? Anything to collapse, that is the surface tension whenever there is air-water interface. Okay? So surface tension collapses, but surfactant decreases surface tension, especially of the small alveoli. Fine. What happens if the surfactant is absent? Surface tension is high. So what will happen? Alveoli will collapse, right? So this happens in cigarette smokers, premature infants of diabetic mothers, and this is known as IRDS, right? And it leads to atelectasis, and it is also known as hyaline membrane disease. Fine. Okay. Next, very simple question, but still many students make a mistake. Beta, surfactant, very important. Maybe the tracheobronchial tree doesn't come, but surfactant will come. Oxygen dissociation will come. The regulation will come. Okay, so non-respiratory function of lungs. First of all, to learn HAC. It releases histamine, arachidonic acid, kallikrein, IgA, surfactant. Right. This second function is what confuses the kids, right? It has ACE enzyme. Lung has ACE enzyme, which is zinc containing. Okay, both are the questions. ACE enzyme, which helps in formation of angiotensin II, which participates in RAS, which helps in the sodium balance of the body. So when the question is framed, वो ऐसे frame कर देते हैं. They don't give you a direct thing ke ACE. They give you what is the non-respiratory function of lung, the sodium, maintenance of sodium balance. And then you get confused. Fine. So sodium balance is the answer. Next, ACE enzyme, beta. This is also very important. Lung. Fine. Acid-base balance. And they all, produce something known as these substances, no BAPs. These substances are removed by lung from the blood. Okay, so this is just an additional function. Abhi tak question has not been framed on this, so let us not waste time, right? And just know HAC and just know angiotensin formation, ACE enzyme, fine, and acid-base balance. Good, done, beta. Very good. Lecithin, DPPC, surfactant, please remember. Okay. Next is compliance. Compliance, everyone, important. Stretchability hai. Okay, it is the stretchability, not elasticity. Okay, ye yaad rakhna hai, you have to remember it. Stretchability. It is delta V by delta P in the graph. Two important questions. Either they give you a question like this. Jaldi se answer kar do. You all know it. Tidal volume is around 600. At inspiration, pressure changes from -4 to -8 centimeter H2O. What will be the compliance? Answer kar do. Delta V by delta P. I don't need to answer. Calculate karo beta. 600 by -4 -8. 600 by 4. What it will be? Right? So please remember, these kind of easy calculations can come in your exam. ठीक है, mental है ये तो, ठीक है, mental calculation है. Next, this graph can come. Fine everyone, so I want you to repeat with me. In emphysema, the compliance increases. In fibrosis, the compliance decreases. Right? Very good. Very good. See, easy thing. Any calculation, if it is coming in your exam, it will be very easy. Something like 100 by 2, 200 by 4, something like that. Okay, don't panic when you see such questions. It's okay. Any kind of question, beta, welcome it. Fine. Just keep on answering the questions and, don't lose confidence if you are not able to answer a question. Fine. Okay. Next, everyone, please note, the chest wall compliance is more than the lung compliance, which is more than the total respiratory system. Fine. Okay. Next, V by Q ratio. Recent exam questions, they keep on asking this a lot. So this is my favorite diagram. Fine. I draw it like this and all my things are sorted. Draw like this. You know where the alveoli are biggest in size. Apex. Smallest, base. If a thing is small, then you can expand it. So where the lungs are having maximum expansion, base. Okay? Yes, Dr. Harsh. Very good. Yes, correct. But emphysema, fibrosis, graph will be given. A, B, C. You would have to choose. And emphysema, compliance increases. The examiner loves this question. He just loves emphysema with compliance. So learn कर लो, confuse नहीं होना है बेटा. ठीक है, your exam should be like, I know this question, fine, done. And then there will be certain questions which you will not know. So the questions which you know, mark them carefully. Fine? Okay. Next, ventilation, perfusion. Obviously, imagine करो, gravity act कर रही है. Ventilation, perfusion will be maximum at the base. Finish. It will be very less at the apex. But there is a catch. The V by Q ratio is maximum at the apex. Learn करो. Very important recent question. Ventilation, perfusion. Just apply common sense. कहाँ maximum होगा? Base. But the ratio is opposite. Fine? Done? Okay. Next, intrapleural pressure is more negative at the apex. Intrapleural pressure is less negative at the base. These are all the most probable questions which you can get from this diagram. Fine? Okay. So what is the V by Q ratio? Beta, V by Q ratio is very important topic. So please learn. If they just give you lung, 0.8, learn karo. 0.8. If they give you base, so less है वहाँ पे, minimum है वहाँ पे, 0.6. But if they give you where is ventilation more, most, maximum, base. Ratio is different. Ventilation, perfusion separately is different. And V by Q ratio is at the apex is around 3 to 3.3 in the standing position. Done? Ye question do not do wrong. Nobody should do wrong. Fine? Now, very easy mechanics of respiration. Inspiration is an active process. Main muscle is diaphragm. Why? Because the 70% of the tidal volume is because of this. Fine? The ribs, they do participate, but less than the diaphragm. So, if they ask you which is the main inspiratory muscle, diaphragm. Fine? Please remember, I is for E and E is for I. In inspiration, the external I, learn kiya beta? Yes, Dr. Harsh, we will take the, and Doctor, yes, correct. खुद लगाओ दिमाग. V by Q infinity कब होगा? We will discuss it. But first let me do what I have planned for you. All the questions I will take at the end. Fine बेटा, ताकि flow बना रहे, and we have to finish medicine and pharmac also. Fine, तो जल्दी करते हैं. I is for E and E is for I. Right? Inspiration is because of external intercostal. Expiration is because of internal intercostal. Fine. Next, accessory muscles like scalene, sternocleidomastoid, abductors, like posterior cricoarytenoid, all of they help in the inspiration, but they are accessory. So main कौन है? Diaphragm. वही question आएगा, right? Or this question can come. Fine. Expiration is passive. We do not have to make any effort for it, right? If we have to do a forceful one, then it is active, and then we use the accessory muscles, which are the adductors of the vocal cord. Fine. Otherwise, no muscle required. It is just because of the elastic recoil, we have the passive expiration. Done? Very good. Quickly, respiratory pressures. जल्दी खत्म करते हैं. Few points are left. Respiratory pressures. Just remember, beta. IAP, the intra-alveolar pressure, normal is 0. In 0 matlab it is not 0, it is equal to atmospheric pressure. Inspiration -1, right? Because we all know the Boyle's law. Boyle's law क्या कहता है? Volume and pressure are inversely related, right? So when the pressure decreases, volume increases, and that is why in inspiration we have to fill air. Right, so there occurs -1 or 759 mm of Hg, and inspiration पे 0, expiration is +1 or 761 mm of Hg. Please note this 0. We just say 0 because 0 is in in comparison with atmospheric pressure. Fine. Intrapleural pressure, important question. Always negative. Why? Because it is what is preventing the lung, the pleura to not collapse, not push the lung and not let the lung collapse. Okay, so it is like a suction pressure. Intrapleural pressure is always negative. Why? Because two reasons, both are questions: elastic recoil of lung and drainage of excess by the lymphatics. Fine. So lymphatics are playing a role and elastic recoil. So normal is -2 mm Hg or -5 cm H2O, and during inspiration it becomes obviously more negative, -6. At expiration it comes back to normal, -2. So never in a normal respiration it is positive. When will it become positive? When we do forceful expiration. Okay? Like in Valsalva maneuver. Valsalva maneuver is what? Expiration when the glottis is closed. Fine. Then what happens? Maximum. We are doing a very forceful expiration. Then it becomes maximum positive. Normal mein always negative. Muller's maneuver mein it is maximum negative. What is Muller's maneuver? It is inspiration in when the glottis is closed. Fine. Transpulmonary pressure, it is the difference between the IAP and intrapleural pressure. It is also positive. It is always positive. Fine, because the intrapleural pressure is negative, and whenever you will do minus of minus negative, it will become positive. Fine, so it is positive. Done, beta. Now quickly let us see these things. What is this? This is the hysteresis loop. Hysteresis loop क्या होता है? The compliance is different during the inspiration and expiration. That is the hysteresis loop. That is why we get a hysteresis loop. Fine. That is the only question you have to do. Fine. Next, beta. क्या repeat करना है बेटे? Okay. The flow volume loops. Flow volume loops, beta, only 3 loops. Have a look. That's it. No explanation required in this. I think now you can see it. Okay. Okay. Now, can you see this blue one, everyone? This is the normal flow volume loop. When we have a obstructive disease. So you just have to look for two things. One is kinking. Expiration. See, above is expiration, below is inspiration. You have to just see two things. Kink hai to obstructive hai. Plus here what happens? The residual volume increases. Fine. Restrictive may overall it is a smaller graph. Fine. It is a smaller graph and there is no kink. These are the two which I want you to just have a look, because that is only what is going to come in exam. Not a very difficult thing, because it is not INI. INI may further hota hai. Fine. So let us just have a look at this diagram, everyone. Black one is your normal. The green one, can you see this kink? Is the obstructive. Obstructive is further left. Fine. And restrictive is on the RR. Just remember RR right. On a little bit right side. Fine. So kink dekhenge. We will see the residual volume, and kink se hi we will get to know whether it is obstructive or restrictive. Fine. The purple one is for fixed upper airway obstruction. It's a very cute graph, so you will never make a mistake. I don't think so this will come. For us, majorly obstructive will come. Okay. Fine. So this is the normal graph. Normal graph. This is expiration, inspiration. If I have to make for, then I will have a kink. This is obstructive. Simple. If I have to make for restrictive, overall graph will be smaller on a rarer right side. Fine. This is TLC. This is RV. And in between these two, it is FVC. Forced vital capacity. Fine. If you don't know, just know the shape. Normal कैसा होता है, obstructive कैसा होता है, restrictive कैसा होता है. Finish. Done. Next. Dr. Saurabh, kink क्यों दिखता है? In maybe next 20 minutes, you'll know when we do the medicine. ठीक है? चलो. Very good. Next is decompression sickness. See beta, decompression sickness, dysbarism, diverse palsy or Caisson's disease, it occurs when there occurs rapid ascent. Rapid ascent. What happens? Nitrogen gases, they get dissolved into the nervous system when a person does a rapid ascent. Niche jaane mein nahi. When he comes up, then the nitrogen gases come out and they lead to this. Fine, it can occur even in the aviators, joint pain, coma, muscle weakness, all that will occur. N2 narcosis occurs in the descent. Fine. Okay. High altitude. High altitude, very important, at least 5 questions. What is acclimatization? You all know acclimatization is how we get used to the high altitude. In acclimatization, we will have more RBC. We will have what? More erythropoietin. We will have metabolic alkalosis. Okay? All of this will help us, erythropoietin will help us acclimatize with the high altitude. Fine. Cerebral edema. Cerebral edema may occur when somebody goes to the high altitude. Right? And at high altitude we get hypoxia. Hypoxia causes the oxygen dissociation curve to shift to right. And one question from the Pharmac. What is the DOC of mountain sickness? Acetazolamide. Right? Very, 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 very important. So all these questions can come from high altitude. Erythropoietin itself is very important. That we will do when we do the blood or kidney. Right? Next, oxygen transport, you all know, maximum by oxyhemoglobin, very less is dissolved in the plasma. CO2 transport is maximum as bicarbonate. Right? This question is a repeat question. How do I transport CO2 as bicarbonate maximum? Fine, everyone. And okay, last topic for the physiology is the reflexes. Not last, second last. There is one more topic left which we will do. Reflexes. See, Herring-Brewer reflex. How do you stop inspiration? Take a deep breath, everyone. Taken, you stop. How? How does the lung know when to stop? Expire karo beta. Lung knows when to stop. That is herring-brewer reflex. Finish. During swallowing, you don't breathe. You all know that, right? Then J receptor reflex. This is a reflex especially by a chemical capsaicin. What happens in this? In this, the juxtapulmonary receptors in the alveolar wall are activated and impulse passes through vagus nerve through the C fibers. So all these three things are important. Stimulus can be ARDS or capillaries are engorged, but this is very important question. Which chemical leads to the J receptor reflex? Fine. And what happens? This is again a very important question. What happens? Bradycardia, not tachycardia, bradycardia, bronchoconstriction and rapid shallow breathing. That is what is happening. Fine. Then there is a reflex which is only present in the first cry of newborn. That is Heath's paradoxical reflex. Right. What is that? First, baby is born and he cries. Right, he cries. So air fills in the lung. Now, lung has to fill more air. So that is a positive response. More and more stretching occurs. Fine? Okay, everyone. Next. Okay. Please remember two more points, beta. Carbon monoxide poisoning. What happens? We do not see cyanosis. No cyanosis is seen. Right? No cyanosis is seen, but still we see a cherry red flush. So how will you remember? They give you this question. They write something long and they say the person is having cherry red flush. So remember this term, cherry red. Mona loves cherry. Carbon monoxide poisoning में cherry red flush आता है. Right? And methemoglobin. What is methemoglobin? Normal is Fe plus 2, but it gets converted to Fe plus 3. Fine. So methemoglobin here, chocolate brown hemoglobin occurs. These are the two terms which you should know. Fine. Okay. And hypoxia. Hypoxia, everyone, very important. Few important points about them. Most common hypoxia is hypoxic hypoxia. Fine. And in the anemic hypoxia, everything is fine. But what is wrong? The hemoglobin is wrong. Right? Hemoglobin concentration, oxygen carrying capacity is wrong. AV oxygen difference, the arteriovenous oxygen difference, very important, learn it, is more in stagnant and less in histotoxic. Okay? So stagnant hypoxia में and histotoxic hypoxia में, how will we differentiate? We differentiate by AV oxygen difference. 100% oxygen is very much helpful in what? Hypoxic hypoxia. Anemic may be little bit, but no value in histotoxic. Histotoxic में cyanide is working against it. Fine. So cyanide is, everything is fine. The person is fine, but cyanide is not letting the oxygen to be utilized by the tissues. Fine. Brain in hypoxia is the first organ to be affected. And in hypoxia, we know right shift occurs. And please note again, this question has come many times. Anemic hypoxia, carbon monoxide poisoning, peripheral receptors are not stimulated. So how will you remember? कहाँ cyanosis है, कहाँ नहीं है? So let us write hash. Hash and just say yes, no, yes, no. Hash, yes, no, yes, no. Fine. Yes, no मतलब H में cyanosis is there, central cyanosis. A, anemic में no cyanosis. Because why? Anemic में blood is less. If something is less, how can, the reduced component be even less? Fine. So S, stagnant may yes, and and the histotoxic may again no. We don't see any cyanosis. Fine. hash. Remember, for cyanosis, beta, cyanosis can come, peripheral receptors can come, and as such, you know, the hypoxia is very important. So I want all of you to, you know, learn hypoxia very, very, very well. Fine? Okay. Next topic, everyone. Okay, is this graph. Okay, this graph, everyone, do not mess up with the values. Simple, रटना है, समझ नहीं आ रहा है तो you have to learn it. Fine. So what this graph can come, A, B, C, D, E, F, they can give you the terminologies and you would have to learn it. Fine. So please note what is what. So let us just quickly revise it. Okay. See, what is tidal volume? You have to know. Normal air, normal inspiration 500 ml. IRV, inspiratory reserve volume, air inspired, excess of TV with maximum inspiratory effort. Right? You have to remember this, beta. If you have not learned, you have to learn it. I don't want to waste your time and read all of this, and you know, so that you have not even learned it right now. So learn this. This is very important. One volume is coming, okay? Either residual volume or something. I just want to highlight one fact. We can measure everything by spirometry, but not residual volume, FRC, TLC, anything which has the RV in it. So for that, for the residual volume, we use heme dilution method, which is the best, body plethysmography, and N2 washout method. Right? So please remember this, residual volume we cannot measure with spirometry. Beta, whatever I have to repeat. Yes, Dr. Shruti, very good. But that is what is the work of physiology, right? Physiologist. If you were doing physiology, then I would have really told you all this. ठीक है ना? सब कुछ होता है. पहले क्या होता है, बाद में क्या होता है. But आपको main क्या याद रखना है? Right shift. Fine? Okay, let us move forward. So beta, this I am trusting you with. You have to learn. And इसका एक easy तरीका मैंने निकाला है, which you have to know. See beta, vital capacity question comes. What is the maximum amount of air that you can take in after maximum expiration? VC, vital capacity. Right? What is FRC? FRC is what air remains in the lung after normal expiration. So FRC is ERV plus RV. Very important formula. They can just ask you this. Fine. Then these are the certain formulas which you should know. What is pulmonary ventilation? TV into RR, respiratory rate 500 into 12. Normal respiratory is 12. Right? Alveolar ventilation. What air is going into the alveoli? Fine, that is tidal volume minus the dead space. Dead space was 150 into 12, right? So it is 4.2. See, as far as, you know, the recent trend is, they are not focusing on the values. You have seen the papers, but they are focusing on the concept. Okay? So alveolar ventilation is a concept you should know. Tidal volume minus the dead space into RR. Fine. Physiological dead space is anatomical dead space minus alveolar dead space. Normally, both are equal. Physiological and anatomical, they are equal. Because alveoli do not have any air. That occurs only in the diseases. Fine. Then closing volume. Alveoli, they will get closed at this volume, which is around 10% of VC. And it increases to 40% of VC. So beta, this much you should know, ventilation and everything. Now, how will you remember it? Okay. For this, there is one easy way to learn. If you ever forget the diagram, which you can, right? Anybody can forget. So please remember, you know, make your hand like this. Fine. This is the only way we can learn in the examination hall. If we forget, we cannot draw. Right? So with our hand, right, we can easily remember. So if you do like this, right, this much is tidal volume. Make karo beta, just make this hand on a rough paper, it will become very easy, right? Whatever is excess is IRV, down excess is ERV, whatever is left in the lung is RV. RV never comes out, and that is why in spirometry we cannot measure it, right? Because residual volume never comes out. Fine. Now this TV plus IRV is inspiratory capacity. Practice making this hand once, it will become very easy, capacities and everything, right? IRV and this ERV, they all, and the tidal volume is the VC. Everything, all the things are the TLC. Okay? So if you do like this, these are the probable questions which are going to come. What is FRC? It is going to come. Definition, and if possible learn for the residual volume, for tidal volume, the numerical value. Okay? Vital capacity ki learn kar lo. Otherwise, if you don't remember the values, it's okay, because recent trend shows that they will focus on the concept, right? So this hand is a new thing, right, which I thought I must share with you all, so that you never get confused. Make kar liya beta everyone? Okay, so this we have done. Very good. Done. So physiology is over. Fine. Okay, now before I start with medicine, okay, very good. I'll be taking a class till 11 only, and I'll be taking a part 2 tomorrow. So today and tomorrow we will finish all the medicine and pharmacology related pathology, and if time permits, micro. Fine. So now beta, okay, doubts beta at the end I will take once everyone is done. Fine. Okay. Now everyone, see beta, abhi I just heard a dialogue in a movie. Like, there are, many kinds of people, though it was very, I think, a little bit derogatory. We should not call anybody a loser or a winner. Everyone can win. So, but a very famous actor, Shah Rukh Khan, he used this in his film. He said, there are two kinds of people in the world, winners and losers. Okay, if you broadly take it. And but life gives many chances, but maximally a very big chance one time to change where you are and where you have to go. So if you think you fall into a category of not a winner, life is giving you a chance. Grab it, don't let it go. Okay? 49 days. Don't sleep, don't eat, don't talk to your girlfriend or boyfriend or husband, wife, whatever, or your parents. Don't talk to them. Tell them 49 days I am gone. Fine. So 49 days I want nobody should know who you are, what you are doing, have you brushed your teeth, have you eaten your food. Kuch nahi, only study. And then you can jump, change life. Soch ke dekho beta, not a big bargain, 49 days, that's it. Fine. Every subject revise karo, every subject ko collectively revise karo, whatever it is, and that is why I wanted all the 4 subjects to be done together. Fine. Chalo. Right beta? So every life gives you a chance. Maybe this is the golden chance. Okay. Now, ready for medicine? Jaldi batao, ready? Ke thak gaye? Tired? Tired ho gaye ho? Tired ho gaye beta? Yes or no? Because I can still do it. Okay, I can still do it, because I never say to myself, I cannot do this thing. I can do it. Right? So are you tired? Shall we start with medicine, sure short things which are going to come in your exam, and pharmacology? Okay. Ready? Chalo. Beta, be ready to change your life. Be charged up. See, you are going to be mentally, let down. Obviously. It's such a bad phase of your life. But I am telling you, 49 days, you have got the chance to become a winner. Fine? Chalo. So, start karte. Not tired. Very good. I am also not tired. Okay. First, asthma. Asthma. Drug bhi aayegi. फार्मा भी आएगा, फिजियो भी आएगी, सब कुछ आता है. ठीक है. सो एस्थमा, लेट अस स्टार्ट. सी बेटा, इन एस्थमा what you have to remember, it is first of all reversible. Asthma reversible, COPD, emphysema irreversible, bronchiectasis irreversible. First question तो यही हो गया, खत्म. Right? So out of all the obstructive diseases, which is reversible? Asthma. Right? Here airway hyper responsiveness occurs. Fine. Airway hyper responsiveness occurs. Reversible hai. We usually get dry cough. Sputum can also be there. Night cough. Night cough, two causes, GERD and asthma. Smooth muscle constriction. Reversible spirometry. Beta, again and again this is coming. Why? Question hai ye. How will you reverse it? There is a patient. You give salbutamol. FEV1 improves. Reversible. So what happens? Improvisation occurs if some agent is given. Fine. Then pathology. Pathology. CCC. C beta, AC hota hai, which we are not using right now. AC. So asthma has CCC. 3 C's. Fine. One is Charcot-Leyden crystals. ठीक है. Kirschmann spiral Crayola bodies. Charcot-Leyden, they are eosinophils, granules. Kirschmann spirals, they are whorls of epithelium shaped mucus plugs. And Crayola bodies, they are like columnar cells which have slough. ठीक है. तो 3C for asthma. To check reversibility, अभी बताया salbutamol. Salbutamol दिया. What happens? Spirometry किया, FEV1 starts to improve. Cold air, it causes worsening of the symptom. That is why at night, maximum asthma attack occurs. Why? Because the FE1 reduces in the cold air. Right? This is a very old test, not now done, methacholine challenge test. We give methacholine, the patient worsens. So now we don't do any test in which the patient worsens. We do only the salbutamol test. Fine? Okay. So beta, this question will come. How will you check whether the patient has asthma or COPD? कैसे पता चलता है हमें? By salbutamol reversible test. Fine? Repeat question, repeat question. Extrinsic asthma, intrinsic asthma. Now beta, please remember question क्या आता है? Intrinsic पे. Intrinsic is due to aspirin. ठीक है? It is aspirin induced. So A for aspirin, A for adult. It occurs in adult. Fine. It is very rare. Anything which is rare in medicine is severe. ठीक है. So ये rare होता है, less common होता है, but more severe होता है. Please remember this beta. Type 1 diabetes mellitus, type 2 diabetes mellitus, which is less common. Type 1, but वो severe है. Right? Anything which is less common is more severe. Done? Okay. Next. This is associated with polyps. Polyps, aspirin, asthma. This is known as Samter's triad. Learn kar lo. Samter triad. Here we do not see any IgE. Extrinsic क्या होता है? Something is coming from outside causing asthma, allergy. Allergy होगा, IgE will increase. Young people will have this. Fine. And this is not aspirin induced. And this will have family history. Done beta? Direct, Ramu, a patient has no family history. Whenever takes aspirin, he might have polyps. He gets asthma attack, which is very severe. So it is intrinsic asthma. Fine? Very important. So these are Kirschmann spiral, right? You know what it is, spiral mucus plugs. And these are what? Which C is this? These are Charcot Leyden crystals, the eosinophils, right? Okay. Next, beta, please remember, they always ask about the severe bronchial asthma. So this chart I've already given you in the while I was teaching, right? Okay. Done, bete. Now, please remember, they always ask about the severe asthma. In the severe asthma, patient ko kya hoga? Will he be able to talk? No, he will be mute. He will be having breathlessness even while he is lying, right? Respiratory rate will be very high, but there might be bradycardia. There might be PaO2 less, might nahi, matlab there is PaO2 less and PaCO2 will be high. Fine. So this is the status asthmaticus or severe acute asthma attack, right? The difference is the respiratory rate. Please remember the point 4. Respiratory rate is increasing. As you know, severity happens, we start using more accessory muscles. Fine. Heart rate, in severe you might have bradycardia. Pulsus paradoxus becomes absent in severe cases. Otherwise, in the normal, it will remain normal in the milder and the moderate cases. But as severity increases, it becomes absent. So these are the 4, 5, 6, 7 points. The 4th, 5th, 6th and 7th points which you might get in the exam. Okay, what is happening in the severe asthma which has respiratory failure? One more thing, if it is a mild asthma, it will lead to type 1 respiratory failure. Whereas, if it is a big asthma, severe asthma, status asthmaticus, type 2 respiratory failure. Samtertrite क्या होता है बेटा? Aspirin, polyp, asthma. Right? Aspirin, polyp, asthma. This is the story of intrinsic. Question क्या आता है? Samtertrite तो आ गया. ठीक है. नेक्स्ट क्वेश्चन आता है, डज इट रन इन फैमिलीज? नो. फैमिली वाला एक्सट्रिंसिक है. इज इट सिवियर? यस. फाइन. ओके. सो प्लीज गो ओवर दिस चार्ट, ऑल दोज हु हैव, एंड जस्ट काइंड ऑफ डू इट वंस. ओके. COPD, राइट? इरिवर्सिबल. ओनली रिवर्सिबल इज एस्थमा. COPD का पेशेंट है, एस्थमा का पेशेंट है, दोनों को वी गिव सैल्ब्यूटामॉल. रिवर्सल किस में जल्दी होगा? एस्थमा में. दैट इज व्हाट इट इज मेंट. फाइन. ओके. 2 टाइप्स, एम्फाइसीमा, chronic bronchitis. Here only learn karo beta, B is the second alphabet and it is type 2 respiratory failure. Fine. So emphysema automatically becomes the type 1. Fine. Chronic bronchitis definition. Okay, doctor had the 3 C's. Okay. बेटा लिखो मत, ये सब कुछ एवरीथिंग इज इन योर नोट्स, उसको लर्न करो. क्रियोला बॉडीज, कर्शमैन स्पाइरल्स एंड शार्कॉट लेडन क्रिस्टल्स. क्रियोला बॉडीज, सी, शार्कॉट लेडन क्रिस्टल्स, कर्शमैन स्पाइरल्स, ये सारे इंपॉर्टेंट क्वेश्चन है फ्रॉम द पैथोलॉजी ऑफ एस्थमा. फाइन. ओके. सो क्रोनिक ब्रोंकाइटिस, यू नो द डेफिनेशन. कफ, sputum on most days for 3 consecutive months, 2 years. यही definition पूछेंगे. Second question, you must know this. Read index. Read index is increased in emphysema, chronic bronchitis, asthma, whatever. So answer is chronic bronchitis. So as soon as chronic bronchitis comes, type 2, बोलो जल्दी जल्दी मेरे साथ बोलो, कौन सा respiratory failure? 2. Definition you learn, right? You have to learn. Then read index increases. Fine. Ye one of the question was, which all bacteria lead to bronchitis? Strep pneumoniae, H. influenzae and Catarrhalis. Staph is not involved. Okay, so the question was, which of the bacteria is not involved in chronic bronchitis? Done. One more thing. B से आपने क्या याद किया है bronchitis का? B is the second alphabet, type 2 respiratory failure. Fine. And B से ही bloater, B से ही blue. So when the person is having cyanosis, when the person is blue bloater. Fine. So here, can you see this person is obese person? Can you see obese? The emphysema is a poor person who is very thin. Very thin. Fine. So symptoms, this obese person is having, see, blue lips. Right? So blue bloater, cyanosis. This person is having tripod position. He's very thin. But bete, his lungs have a high increase anteroposterior diameter or barrel-shaped chest. Hyperinflation or barrel-shaped chest. In emphysema. Emphysema is the pink puffer. Right? So if they ask you which is the blue bloater, BBB, bronchitis. Fine, everyone? Okay. And remember which is thin, which is fat. You must remember. Okay, emphysema, we all know which failure it is. Now I don't need to tell you. This is a pathology question. It is enlargement of air spaces distal to the terminal bronchioles with blebs formation. See bete, asthma, emphysema, the chronic bronchitis, they all are obstructive diseases. Okay? Next, here elastic fibers are destroyed. Compliance को क्या होता है? Compliance अभी हमने पढ़ा, increase. ठीक है, surfactant is also lost and barrel shaped chest, hyperinflation is the answer. Fine. One more thing in emphysema, you have to remember DLCO, diffusion lung capacity. Right, diffusion lung capacity, 2 questions. Which gas are we using for it? We are using carbon monoxide and it is less in the emphysema. Bronchitis में, asthma में, it is normal. Fine. So this is all what you have to remember. Hoover sign क्या होता है? Normally take air in air को in लो बेटे, chest expands. Emphysema में chest goes in, उल्टा हो जाता है. ठीक है? So this is Hoover sign. So emphysema का important point, tripod position. And this is the barrel chest wherein the anteroposterior diameter is increased in a person. Fine. Okay. Beta, जो anteroposterior diameter है ना, even at high altitude, the people who have been living over there, they have it. Fine. Okay. Which is normal for them. Fine. Few important questions about COPD which are repeatedly asked. ठीक है, index for COPD severity, gold criteria. No need to know what is gold criteria, what, where, when, no, nothing. Gold criteria. ठीक है, bad day हो गया, the examiner had a fight at home, or some patient went wrong, he is very terrified, then he will give you the things. Otherwise, no need to learn. Board index is for the lung transplant. ठीक है, ये 2 question they have come. Pathology of emphysema, please remember centry assigner, pan assigner or intraseptal. Centry assigner, CC, cigarette, simple, most common, smoker, cigarette. ठीक है, pan assigner क्या है? Pan assigner is in non-smoker, alpha antitrypsin 1 deficiency. What is alpha antitrypsin? It is beta anti-elastase. Elastase एक enzyme है जो elastin को finish कर रहा है. Right? So alpha 1 antitrypsin stops the elastase. So when it is deficient, emphysema occurs. Fine. So where do we have decrease DLCO, emphysema and interstitial lung diseases like lung fibrosis, hypertension and pulmonary embolism. ठीक है, DLCO is increased in alveolar hemorrhage. I don't think so this will come. Emphysema, fibrosis can come. Fine, diffusion ही नहीं होगा. When it is emphysema, the surface area, the alveoli, all the alveoli, they break. Surface area decreases, so diffusion does not happen. Fibrosis में thickness of the membrane is more, so diffusion does not occur. Fine. And chronic bronchitis में it is normal. Now beta, one more thing. For chronic bronchitis, we use low flow oxygen, right? Because we have to prevent CO2 toxicity. Low flow. ठीक है. Chronic bronchitis इतना ऐसे याद रखो. This is not the reason. Chronic bronchitis is not that serious. ठीक है. Patient can live with it. We can control it and he can live. तो उसमें हम देते हैं low flow. The reason is not this. This is just for learning. Emphysema is a very problematic condition. Whenever you go to a theater, you see that, what is the name? Manoj or something like that, right? That person is having emphysema. He's like this, he's doing, right? That is emphysema. So there we might use high flow oxygen. Though the reason is not this. Reason is to avoid CO2 toxicity. Fine. Bronchitis is which respiratory? Dr. Bholenath, I don't know. Whatever you wish for will happen. Okay? Okay. Next. But whatever happens, I'm going to come and teach you. Every single, week, I'm going to come and take your classes so that you don't get scared of these subjects. Done? Done ho gaya beta? Okay. Now, last 15 minutes. Let us do the pharmacology. The pharmacology of asthma and COPD. Important है. Question आता ही है. ठीक है? So what is the pharmacology? Let us quickly revise all the drugs. Asthma. First of all, everyone, in status asthmaticus. Status asthmaticus, repeat question. What do we give? We give salbutamol, SABA. I will tell you. But first let us learn the question. What is SABA? What is this? I will tell you. We give salbutamol, SABA, oxygen. We might give IV hydrocortisone. Right? Ipetropium bromide can be used. Terbutaline can be used. MgSO4 also we can use. Aminophylline also we can use. But aminophylline we reserve. Right? We don't give much. Why? Because A for aminophylline, A for arrhythmia. Because they lead to a lot of arrhythmia. Right? So these are the drugs which we use for the last of the status asthmaticus. Pata chala kahan? Jahan pe pulsus paradoxus was not there. Jahan pe the person was mute. Person was under comatose. Right? He was not last of the table we discussed. Fine. So this is what we are going to give. Right? These are the drugs given. But the question was which is not given. So we do not give mast cell stabilizer, sodium chromoglycate, and we do not give the Montelukast, which are the leukotriene receptor antagonist, because they are for prophylaxis. So repeat karo mere saath. Sodium chromoglycate, Montelukast, they are for prophylaxis. Prophylaxis can be of childhood asthma, exercise-induced asthma. They are never used in acute asthma. For acute asthma, the drug of choice is SABA. Every situation, SABA, SABA, SABA. For maintenance, we give the steroids. Learn ho gaya? So what is the drug of choice for acute asthma? It is SABA. Drug of choice for acute COPD is also SABA. Right? But agar they ask you what is the drug of choice for only COPD. Only COPD. They have not given acute. They have not given anything. COPD. Then it is, we will use ipetropium. Right? Done? So beta, please remember this. It is very, very, very important. Fine? Okay. Now, Montelukast is a leukotriene receptor antagonist. Now, ये क्या है? ठीक है, पहले हम इसका Montelukast का पहले हम let us see what what am I talking about? है क्या ये diseases, drugs and diseases? Let us see. Okay. See bete, see this diagram everyone, and then you will never forget it. Never forget the drugs. See, this is your mast cell. Okay, for asthma we know it is, yes beta आयुष correct, MgSO4 तो MgSO4 और aminophylline तो last है, ठीक है, वो तो last ही है, they are like reserved, right? But for aminophylline we do not give ultimately because arrhythmia hota hai, so we have to use it very cautiously. That is what I meant. Okay, now mast cells, fine, mast cell hai, they have to release something, leukotrienes, which will cause bronchoconstriction. Fine, mast cell, just above mast cells we have IgE antibody. क्यों? Why? एस्थमा क्या था? एक्सट्रिंसिक एलर्जी था, एलर्जी था तो एलर्जी में क्या आता है? IgE. And you know, when an antigen combines IgE which is present on the mast cell, है ना, ये क्वेश्चन है ना माइक्रो का, which antibody is present on the surface of a cell? IgE. Question है ना? So right, now antigen combines with IgE which is attached to the mast cells. What happens? Even degranulation occurs, other substances are released, leukotrienes are released, and they cause bronchoconstriction. To help for bronchoconstriction, we have bronchodilators. In bronchodilators, 3 categories are there. Beta-2 agonists, which are salbutamol, terbutaline, salmeterol, formoterol. Salbutamol, terbutaline, they are short acting, so we will use them for acute attack. Finish. Salbutamol, SABA, short acting beta-2 agonists, right beta? So beta-2 agonist, they cause bronchodilation. Fine, very important. Whereas salmeterol, formoterol, they all are long acting, right? They all have metro in their name, and metro we are using to travel a little bit longer distances. Fine, so long acting. Now out of salmeterol and formoterol, FF, fast. So this formoterol can be used for acute also. Okay, though it is a LABA, long acting beta-2 agonist, but still we can use in some cases for acute attack. Otherwise, LABA are always for prophylaxis, never for acute attack. Okay, and LABAs ko we always give with the corticosteroids. Why? Because this has been a question in very recent papers. Corticosteroids are always given because they increase the beta-2 agonist activity. Done. Corticosteroids don't lead to the bronchodilation. They increase the activity of other things. Beta-2. Correct, Dr. Ayush? ठीक है बेटा, clear हो गया? Done? Done beta. So please remember, very important, formoterol, salbutamol आ सकता है, and they are inhalational. Fine. What is the side effect? Very important. Please say T. 4T. 4T बोलो, जल्दी से बोलो. Salbutamol का side effect आएगा, right? What is the side effect? Tremor, most common. Tremor, tachycardia, tolerance. See, tolerance is more with LABA. Tolerance is more with LABA. Okay, this is also a question. And T-wave changes. Why? Because of hypokalemia. These drugs may cause hyperglycemia but never hypoglycemia. So, salbutamol, drug of choice, acute asthma, acute COPD, कोई भी acute asthma setting है. Done. And what are the side effects? T. Tremors. Fine bete. Next, in the second category, we can give the parasympatholytic drugs, which are the M3 blockers. M3, activation will lead to constriction. Right? So now what will happen? We gave M3 blockers, ipratropium bromide, tiotropium bromide. They are also inhalational. Right? So this we can use. But ipratropium is a drug of COPD. ठीक है? Acute COPD में again we give salbutamol. Fine? Next drugs are phosphodiesterase inhibitors. Very important name आ जाता है. Aminophylline is what? Aminophylline is phosphodiesterase inhibitor. Phylline, P for PDE, P for phylline. They can be given orally or IV, but they cause arrhythmia, seizures भी कर सकते हैं. Right? If there is a smoker, recent question, we have to increase dose of theophylline. Why? Because of the microsomal enzymes. Right? Smoking is an enzyme inducer. So it will cause theophylline to break easily. सोचो ना, break करेगा. ठीक है? It won't act. So we have to increase dose of theophylline in smokers. Enzyme inhibitors like erythromycin, clarithromycin, we have to decrease dose so that toxicity does not occur. Fine. Next beta, you know leukotrienes पे जो drugs act करेंगी, what are they? See, you all know this cycle like phospholipids into arachidonic acid, COX pathway, LOX pathway. This you have done in your pathology. Via the COX pathway, prostaglandins, LOX pathway, we get the leukotrienes. है ना? COX pathway पे कौन act करता है? The NSAIDs. Fine, which is very important again. LOX pathway पे and the phospholipase A2 को inhibit कौन करता है? These are the drugs which will help us to control asthma. Fine. So steroids act on the phospholipase A2. LOX enzyme, lipooxygenase enzyme inhibitor, xylutone. L आता है name में. So LOX. Just give me 1 second. Right? Xylutone. And the zafirleucast, monteleucast, they act on the LT receptor. Very, very, very important pharmacology questions. Salbutamol तो आएगा ही. Tremors है, acute asthma है, it will come. Okay, but these questions can also come. These are newer questions. Xylutone acts on LOX enzyme. ठीक है? Zafirleucast, monteleucast, they act on LT receptor antagonists. ठीक है? Done. Next, steroids are the DOC for the prophylacsis. They are also used in acute attack and they increase sensitivity of beta-2 agonist. But what is their most common side effect? That is oropharyngeal candidiasis. How do you prevent it? You tell the patient to gargle. You know, this was such an easy question. How do you prevent candidiasis if somebody is taking inhalational steroids? Prevent tha, treat nahi. Right? Treat to you will add nystatin. Fine. Prevent में a simple thing. Gargle after every dose. Finish. Right? Next, mast cell stabilizer, sodium chromoglycate and nidochromil. Fine. Omalizumab. Omalizumab is newer drug which is acting against IgE. Right? So IgE पे कौन act करता है? Omalizumab. This is also for prophylaxis. Fine everyone. Few extra points for the bronchial asthma drugs. Okay. Few extra points. Out of all the drugs, therapeutic dose monitoring will be done for aminophylline. है ना? Salbutamol क्या कर रहा है? Tremor. हल्का सा कुछ टैकीकार्डिया. Therapeutic dose monitoring नहीं चाहिए हमें. Right? वो नहीं चाहिए हमें. Agreed beta? See beta, the GINA guidelines now say that we can just use LABA and corticosteroids in all the situations. But as far as your paper goes, the DOC has to be the SABAs. Fine? Okay. Next. Okay, we have finished this. This we have finished. LABA we have finished. It is always in combination with the inhalational corticosteroids. Ipetropium bromide we have done. Okay. Okay. One more question, repeat question. Which of the following drugs causes paradoxical bronchoconstriction? So that is why also ipetropium is not used in asthmatic cases, as you know, soon as the SABAs are used or corticosteroids are used. Fine. Okay. So that is paradoxical bronchoconstriction is ipetropium bromide. Aminophylline I have told you, asthma, right? Done हो गया, ये भी done है. Okay, Montelukast. Montelukast, I told you, LT receptor antagonist. Side effects is Shook-Strauss syndrome. That can be a side effect. Fine. Next, lipooxygenase enzyme LOX. Xyluton. Right. This will inhibit the LOX enzyme. This is hepatotoxic. So which drug is hepatotoxic? Xyluton. Fine. Very good. Okay, one very recent medicine question in brittle asthma. What is brittle asthma? Brittle asthma occurs in the kids, right? One day they are perfect. Other day they are about to, you know, as if they will die. So this is in children. When one day they are good, the other day they are bad, then third day they are again good. So in that situation, when they get very, very, very bad, we use EpiPen. So what is the drug of choice for brittle asthma? That is EpiPen. Fine, beta. Agar some patient is on a beta blocker therapy, right? Beta blocker therapy pe hai. He has been given a beta blocker. Then you cannot obviously give SABA. Then you can use ipetropium as the first drug. Otherwise, acute attack, exercise करते हुए, aspirin में, pregnancy में, normal में, anywhere you give salbutamol. Fine? Okay, this is one question which had come. Now I don't think it will come again. A drug to be given by nebulizer, the size of the droplet should be less than 2.5. Right? So beta, obviously diabetics में the Shook-Strauss syndrome beta. Okay. This is the only thing in asthma which you need to remember. So beta, asthma, salbutamol remember, which is the drug for prophylaxis, which is for acute attack, which is for COPD, which is for COPD acute attack, which is for which drug is causing tremors, which drug will cause candidiasis, how to prevent it, how to treat it, and that's it. Finish. And of course, see, Xyluton, Montelukast, sodium chromoglycate, these are the drugs we are not using in emergency. Right? So know their function and know they are not used in status asthmaticus. Montelukast pe and sodium chromoglycate pe, sure short question. It has been repeated at least 4 times. Okay? Dr. Rahul, abhi good evening kaise ho sakti hai? Okay, chalo. So now beta, I will have a part 2 tomorrow of respiratory. Again, medicine and the TB. In that, you know, tomorrow I will be covering TB. TB ko beta pathology, microbiology and pharmacology. It has to be on tips. TB pe from the pharmac, one question is going to be there. See, I am telling you the paper. Right? I have... Yes, Dr. Aryan, correct. Correct. Acute attack. Acute COPD nahi. Acute attack in COPD. Otherwise, for COPD, we are using better drug is ipetropium. Okay? Okay. Done, beta? See, if it is a, Dr. Chaitanya, if it is a controlled diabetic, then we can use the steroids also. Right? If it is an uncontrolled diabetic, then it is a problem. So in any case, we have to give SABA. We have to give SABA and we can make use of the other drugs. Steroids we will avoid in those who are like totally uncontrolled. Fine? Okay, Binesh, physio to ho gaya na? फिजियो तो हो गया, अब याद हो गया सबको. Now, can I ask you something? See, beta, tomorrow class is also very important. We are going to do rest of the medicine and TB. TB में से आता ही है question. Asthma में से आता ही है question. So you cannot, mess up. Oxygen dissociation curve, compliance, the regulation is going to come. Thank you, Dr. Rahul. Thank you. याद हो गया है? तो चलो एक आंसर कर दो जल्दी से आंसर करो. रिवर्सिबल क्या है? एस्थमा है या सीओपीडी है? रिवर्सिबल क्या है बेटा? जल्दी से लेट मी सी इफ यू हैव इवन अंडरस्टूड. रिवर्सिबिलिटी टेस्ट फॉर एस्थमा, चलो बताओ. वेरी गुड. Everything. Bronchiectasis irreversible, bronchitis irreversible. Read index किस में बढ़ता है? Read index. There is a patient of hyperventilation. Oxygen dissociation curve will go where? Very good. Tomorrow you will know what is FE1. वो भी हम tomorrow करेंगे, ठीक है? We will go step by step. Okay? Very good. यही question है. Which index is for lung transport? Transplant. See, रात में सब कुछ उल्टा पुल्टा होना शुरू हो जाता है. सो वी विल कॉल इट ऑफ. एंड लंग ट्रांसप्लांट के लिए विच इंडेक्स? राइट लेफ्ट कंफ्यूज हो गए. मैथ्स चलाओ एवरीवन. हाइपर वेंटिलेशन करो. हाइपर वेंटिलेशन एक बार कैसे करेंगे? हाइपर वेंटिलेशन, हाउ विल वी डू हाइपर वेंटिलेशन? लाइक दिस. क्या हो रहा है? Oxygen going in, CO2 coming out, CO2 coming out, CO2 coming out, CO2 coming out. PCO2 going down, low, la. क्या बनेगा? ला क्या बनेगा? लेफ्ट, है ना? बोहर का अपोजिट. डबल बोहर इफेक्ट हमें प्लेसेंटा में दिखता है. बोहर इफेक्ट नॉर्मली यू एंड मी. डबल बोहर इफेक्ट प्लेसेंटा, बिकॉज वहां पे बोथ साइड का ब्लड होता है, राइट? वी हैव फीटस, वी हैव मदर, एंड इन बिटवीन वी हैव प्लेसेंटा. सो डबल बोहर इफेक्ट वी सी देयर. फाइन, आ गया ना सबको समझ? सी बेटा, व्हेन यू आर इन एग्जाम पे अटेंशन, ठीक है? फाइब्रोसिस में कंप्लायंस को क्या होता है? एम्फाइसीमा तो मैंने बता दिया. फाइब्रोसिस में क्या होता है वो भी बताया है. फाइब्रोसिस में डाउन. ओके, वेरी गुड. सो आई होप आज जो हमने पढ़ा है उसमें आपको प्रॉब्लम नहीं आएगी. ओके, टेल मी वन क्वेश्चन. देयर इज अ पेशेंट रामू who is sitting in a tripod position, who is having difficulty in breathing, who is very thin, who is having pink skin. Why pink skin? Pink puffer. Why? Because he is putting in so much of effort, है ना? तो pink हो जाता है वो. And when the x-ray was taken, I saw a barrel chest. What am I dealing with? And what am I dealing with is fine. Next question. What is going to be the DLCO? Diffusion lung capacity क्या हो जाएगी इस केस में? Yes, remember emphysema, pink puffer. See beta, this emphysema will come. Pathology part भी आ सकता है. Centriosiner, panosiner, interceptal तो is not that important. Fine. So good. Meet you tomorrow. Same time, 9:15. We will completely do the respiratory system. Okay. Tomorrow, especially, I am taking TB. So be there, everyone. TB is very, very, very important. ठीक है? उसमें we will do the micro part also. So that at one place only you have everything. अब ये थोड़ी है कि जब माइक्रो पढ़ेंगे तब टीबी पढ़ेंगे. नहीं, टीबी पढ़ा है, माइक्रो खत्म करते हैं, ZN स्टेन खत्म करते हैं. डॉक्टर राहुल, बीबी ब्लॉटर, क्रोनिक ब्रोंकाइटिस. ठीक है. नो, विच रेस्पिरेटरी फेलियर इज इट? फाइन, वेरी गुड. So we have finished a major chunk of physiology. Pharmacology, half we have done, and half of medicine is left. Fine, so that we'll do tomorrow. Good night. So jao and think about it. Think about changing your life. See bete, everything, I just read this line somewhere. Everything happens twice. Okay? Whether it is a relationship, whether it is, I don't mean that relationship will occur twice. It can happen many times, right? It can be one also for lifetime. But what I mean is, one is the preparation that you do in your mind, right? Okay, how I will move forward in this relationship. And the second is the actualization. So think about it, how you can change your life. And I am there to help you. We are there to help you. Fine? Go bete. Yes, ड्रीम्स में नहीं, सोच में. ड्रीम्स में जो होता है ना बेटा, दैट इज नॉट हैपनिंग, राइट? दैट इज वाई पीपल से इफ यू रियली वांट समथिंग टू हैपन, डोंट स्लीप, डोंट वॉच अ ड्रीम. ड्रीम इज समथिंग दैट मेक्स अस फील गुड. नो, वी डोंट हैव टू स्लीप. सो 49 days, change your life. Good night. Yes, Dr. Saleha, absolutely. Change your life should be, written on your table. Okay, you have to do it. You can do it. Can I do it? नहीं है question. I can. I will. ठीक है? Will I? Can I? होगा नहीं होगा, छोड़ दो. I can do it. Whatever you can do in these 49 days to change your life, do it. Bye, beta. Yeah, Dr. Jibran Jyoti, yes, maybe. Yes, Dr. Dipanga, we all can be so many places, right? So, come back. Yes, Dr. Nilakshi, I think this video will be available. Of course, Dr. Binish, I'm not leaving any one of you. You know what? You people are studying, suppose 15 hours. I'm also studying 10 hours because I have to integrate the 4 big subjects: patho, micro, medicine, pharmac, and your physiology. By end of this, whenever the series ends, I want you to be champions in these 4. Fine, at least these 4 pharmac questions. Xylitol kya drug hai? I don't know. This should not happen. Xylitol, LOX inhibitor. This should be your response, and if you are able to do that, then the series will be good. Dr. Bhumika, maths karo. Maths karo. Hyperventilation में CO2 goes out, 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 out. CO2 is not inside. CO2 goes out. Blood में क्या हो रहा है? क्या हो रहा है blood में? CO2 का PO2, PCO2 going down. Low, 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 la, la, left. Fine? So just sing the song, and whenever you are stuck in the volumes, make that hand. Fine? It is not a good gesture, but make that hand in your mind, and volumes and capacities will be sorted. Okay, beta. Bye bye. Good night. Go, beta. Leave. Everyone, please go and change your life. करके दिखाओ.